Hi, this is Stephen Carter. I'm a colorectal surgeon at the University of Oklahoma who specializes in inflammatory bowel disease. I apologize for missing the talk, the conference that was given about a month ago. I unfortunately had the flu, and I was so disappointed and so embarrassed that I made sure I took a copy of it and sent it to the organizer of this conference, Dr. Tung, so that she knew that I wasn't a complete slacker. And again, I completely apologize. Let's go ahead and get to it and get started. Looking at goals of surgery, the main goals we're going to have are to alleviate complications, alleviate symptoms. We're going to try to make people's lives better, make them feel better. We want to achieve the best quality of life as possible, and we want to, in the back of our mind, always be thinking about bowel conservation. We don't want to go crazy and try to resect everything possible out there. We want to, conserve as much bowel as we can. It's very important to remember that surgery should not be viewed as a failure of medical management. I often have to have this talk with patients where we sit down and we say, look, we're going to do this surgery so that you can get back on your medications and avoid surgery in the future. It complements it. It allows it to work better sometimes. And so it's really important to kind of remember that. We don't basically go from gastroenterologist to surgeon and then be done. We go back and forth. And it's real important to remember that. Looking at sort of indications, these are kind of the basic indications that we'll use to operate. Failure to thrive is one of them. Dysplasia is one of them as well. Failure to thrive is sort of where a patient doesn't gain as much weight as they should, go through certain stages of life. They'll look younger than their expected age. Dysplasia is where you have precancerous growth start to occur. And we want to do something before that turns into cancer. Fistula is where we have connections between portions of the bowel. That usually requires some sort of surgery to fix. Looking at emergent indications for surgery, these are things that we want to avoid doing. If you kind of compare any surgery, doing it in the middle of the night is not going to have the same outcomes as doing it during the day. These are going to be much worse. We certainly prefer elective surgeries versus emergent surgeries. Looking at emergent indications, number one would be bleeding. That's sort of self-explanatory. Perforation is where you have a hole in the intestine. Obstruction is where you get blocked and things can't pass through. And then toxic megacolon is where the colon gets dilated and very sick. And that usually requires aggressive medical management, and if that fails, surgery. And these are things we want to avoid. Functional results aren't as good, patients aren't as happy, those sort of things. Looking at the types of surgeries, there's Crohn's versus ulcerative colitis surgeries. There's some similarities, but some important differences. Emergent versus elective, we sort of talked about that. And then nutritional status. It's very important to look at the nutrition of a patient. Greatly changes what sort of surgeries we'll offer. Looking at Crohn's surgery, again, our goal in Crohn's, this is a disease we cannot cure, unlike ulcerative colitis. So we need to just take care of the areas that are having problems and leave the rest. The nutritional status plays an important role in determining what type of surgery we're going to do. And really what's important is a multidisciplinary approach. You need to have the gastroenterologist and the surgeon communicating regarding what type of surgery needs to be done and what each of their goals are going to be. And then location is extremely important. Location is going to determine the morbidity or kind of associated functional impairments or functional problems you'll have, whether that's going to the bathroom too often, having leakage, all of these sort of issues. The location really determines that. And it's important to kind of keep that in mind when we're doing these surgeries. Looking at sort of the types of surgery for Crohn's, one of the surgeries that's not used as often as it probably should is a stricturoplasty, and that's basically where we open up a narrowing without any resection. It obviously has an advantage in that you're not going to take any bowel out. It isn't frequently used. We usually now will just resect that portion of the bowel, particularly because of the location again. But When you do a resection, you always worry about when you put these patients back together about that having a leak. And so if they're very poorly nourished, sometimes we won't even try to put them together, and we'll just bring up that ostomy that we talked about previously. So it's sort of important to keep that in mind when we're considering surgery. In addition, the you worry about having some more colon removed than you need. That's important to kind of remember as well. Looking at kind of colectomies, we used to in the past, they just take all of it out and do better, less chance of Crohn's coming back in the colon. But now we sort of say, look, if it's just a portion of the colon, just take that portion out. You don't necessarily need to take it all out. Oftentimes that ends up happening anyways, but removing just a portion is certainly acceptable practice now. And then looking at sort of the removal of the rectum, that is a much bigger surgery. The rectum is basically the last sort of foot of the large intestine. It's about 9 inches long, and that area there is harder to take out than the several feet of colon that's in front of it. And there's a lot of other problems taking that area out as well, such as bladder problems, sexual problems, fertility problems. And so we really want to be careful about going straight to a proctectomy, particularly a young patient that's going to really have some issues with those above problems. Kind of talking about Crohn's, other things, ostomy considerations. We want to have a good discussion with the patient about how they're doing with other issues. If they're having a lot of issues with incontinence or having too many bowel movements or diarrhea, an ostomy may be actually better, even though they could have a connection. We want to make their quality of life as great as we can make it. We want them to be able to do things, whether that's going to the movies or going to football games or parties or whatever they want to do, going on hikes. We want to make sure they can do those things. And sometimes an ostomy is the ticket to doing that. And we need to have a good, frank discussion with them. And we always need to remember cure is not possible. And medications are very important. And we need to make sure that we keep that in mind. Looking at ulcerative colitis, one of the procedures that we usually will do for sort of a patient that's sick is we remove the colon. It's good for emergent patients with poor nutrition. It does provide a diagnosis. It avoids that pelvic dissection that we talked about earlier, which is important for fertility, bladder function, and everything like that. And if you kind of look at what most of the patients do, particularly younger patients, most of them will at some point undergo a removal of the rectum down the road. When they get an ostomy, again, quality of life is important. That's sort of a recurring theme here. Patients are very scared of that. They don't want that, and I don't blame them. But it's important to remember that they're actually going to do pretty well with it. And then J-pouch. It's going to give you a high quality of life. Most patients are going to do very well. They're going to have 6 to 12 bowel movements a day. They're not going to have an ostomy once it's complete. They do have some issues with nighttime incontinence. And I always tell my patients, I kind of think of it as a car that it requires fairly decent maintenance and you need to follow up. And I usually will see my patients about every year, or most of them have ways of getting in touch with me, so if they have an issue, they can get in pretty quick. And we have a long discussion about staying on top of things and getting seen before it's a big problem. Kind of how we make a J-pouch. Basically, there's 3 ways you can 3 different sort of timelines you can do it. Some people will just take everything out, the colon and the rectum, and make the pouch. That has a higher failure rate, but the advantage to that is it's one surgery. What I usually do is take everything out and make the pouch and then sort of divert away, make an ileostomy with the small intestine. That to me seems like the best way to do it. That's what most people will do. And then kind of the 3-stage procedure, sort of those emergent ones where we take out the colon and then we come back later and take out the rectum and make the pouch with an ostomy, and then finally we remove the ostomy. And that's a nice procedure too. Of course, the major disadvantage to that one is it's 3 surgeries, and it's sort of a balancing act between that. It's sort of important to talk to your surgeon, kind of what approaches they want to do. Most people are doing a 2-stage approach. Looking at complications of surgery, really important to kind of discuss. Bleeding is obviously a complication of any surgery. An unattended ostomy creation, we always sort of say that's a possibility in any surgery that we do in the abdomen. But it is important, particularly in a Crohn's patient, or a colitis patient, that sometimes those things become permanent. Recurrence of Crohn's, that's sort of the nature of the disease. Misdiagnosis occurs very rarely now, but it does occur. A hernia is going to be fairly common. That's where you're going to have a bulge, and that can be fixed later, but it runs about 20% almost for any of these sort of surgeries. And a leak is where we put the two valves together and it falls apart. That can be a devastating complication. That is sort of what keeps us up at night, makes us worried. Unfortunately, the worst patients that have a connection are ones on steroids. And so we really like to keep patients off. That's why coordinating with GI is so important, getting to them before they need steroids and managing that complication is important. And what I do in my patients is I use the American College of Surgeons risk calculator. It's right there. You can Google that, and then there's a code for J-pouch. That's just a sample. You can also find these codes just by using Google for pretty much any procedure, or you can ask your surgeon. That's how we sort of we name our procedures. And if you put that into the risk calculator, it's going to tell you what your risk is for each surgery. Kind of looking at the important components of surgical care, I think reasonable expectations is probably the most important thing. You don't want to go to someone that say everything's perfect. You don't want to go in there thinking it's going to be perfect. Expectations are very important. I think surgeon experience is important. I think it's important to see someone that does mostly inflammatory bowel disease surgeries. I think sometimes the surgery part's pretty easy, but it's sort of having a good understanding of how the medications work, when to do the surgery, that sort of thing is nice. In addition, there may be some tricks or something like that they know. Or if it's something where you have a narrowing in the small intestine, a stricturoplasty may be a very appropriate procedure, where another surgeon may just do a resection. Enhanced recovery protocol, that's where we sort of kind of go fast. We try to get you out of the hospital. Minimally invasive, everybody wants small incisions. That's not always appropriate, but if the surgeon can't do that, they're not going to offer it. And then remember about life with an ostomy. We've sort of talked about that, and there's a lot of good support groups for that you can talk to as well. It's important to remember that with an ostomy, your quality of life is just as good as without one. And that sounds kind of crazy, but if you actually look at the studies, those patients will have a completely normal life. Remember the goals of surgery. We've sort of gone over this. Again, we're trying to make people's life the best as possible, but it does sort of have a good, long, lengthy discussion about what their goals are, what's possible, those sort of mechanisms. Most patients are pretty understanding about that. Again, my name is Stephen Carter. If you guys have any questions or comments, please feel free to put that in the comment section. I think it'll alert me to those. If you want to have a more personal question or comment, please send me an email. You can get that through the Department of Surgery website. And I'll give you a call back or get you in the clinic. We can discuss things. Again, I really apologize for missing the meeting. I'd like to say it won't happen again, but you never know when you're going to get sick. But again, call me with any questions, and thank you.